And now we'll move on to imaging in very large patients. Well, these two figures basically show. Do I have the? Just speaking to myself, perhaps. Okay. Can everybody hear me now? In the back? Can you hear me? Okay. So basically, these two figures illustrate the growth of obesity in the U.S. As you can see, this is not a Democratic versus Republican Party. This is just the growth of obesity, basically, right? All the red colors actually and the yellows basically mean that the incidence of obesity is actually increasing in some states where they have this colors over 30%, the heaviest being not too far from here, right? Incidentally, and unfortunately, the incidence of obesity in the children is also increasing. As you can see from 1970s to 2000s, you can see that close to about 20% of children are also obese, and almost like more than a third are overweight. What are the consequences for CT? Well, because of the fall in image quality, there can be missed diagnosis. There can be non-diagnostic scans which can trigger repeats. And of course, if you're not careful and put too heavy of a patient on the table and try to move that table, well, it can fail. It can be an embarrassing situation for the patients. And if you are going to use CT for something like CT fluoroscopy, the radiation dose not only will increase to the patients, but also to the staff, to the radiologist or to the technologist who's doing a procedure. Well, so what are the issues exactly? Well, first thing is that will the patient fit? First, we have to get the patient on the table, and the table has to move in so that the scanning can occur. And different tables, the ball bearing or the bearings of the table will only tolerate so much amount of patient weight on the table. So therefore, one has to know what are the weight limits. The other thing is that if you can move the table, the patient then has to go in and out of the CT gantry, especially if you're going to do a chest and abdomen CT. This is not as crucial in head CT, where head doesn't really become big. So it's not going to be an issue, but it will be an issue for chest and abdomen. And then we deal with image quality issues, right? How do we adjust the KV, MA, rotation time, or pitch, or even your slice thickness? How do you take care of the field of view? Because these patients can be bigger by the maximum reconstruction field of view that is allowed by some of the scanners. Kernels, reconstruction kernels, and even iterative reconstruction techniques help, and we should be using them. Well, so this table has been taken from radiographics by this article from Dr. Modica. A very nice article in which basically it's a little bit old, about 2011, so I'm suspecting that this must have been written in 2009, submitted in 2010, so maybe 3 years old. But it does give you an idea as to what's the aperture, the gantry aperture diameter, for different scanners. And as you can see, it can range between 70 to 90 centimeter at the time that this article was written, right? And of course, that's related, also to the maximum reconstructed field of view. Some vendors will only allow you about 50 to 65, while others may go up to 80 centimeter with extended field of view. That's important because some of the abnormalities can be at the periphery of the field of the view. And then, of course, the weight limits. They do vary. And I do believe that some of these weights do go much higher than what is relayed or actually displayed in this table. But it is important that you review your manual or consult your CT vendor and then ask them, well, I do have scanner A, B, C. What are the weight limits? And what's the aperture diameter? The other thing that you have to know is that the aperture diameter does not equal your patient diameter that you can move in and out of the CT. In other words, if you have a gantry that's 90 centimeters, suppose, you do have to account that the table is also going to acquire some space. The table can't touch the gantry while it moves in and out. So you have to subtract about 15 to 18 centimeter. And again, this number can be precisely obtained by your CT vendor. They can tell you, well, this is what you have to subtract from the gantry aperture diameter, So that will decide how much of a patient girth can you move in and out of the gantry. And again, while you're doing that, check the weight limits. How much is the maximum weight of the patient that I can put on the CT scanner? And Diana actually gave me a wonderful trick, actually. She said, well, one of the things that she likes to do is Google bariatric CT. Just to make sure if there is a case and she cannot put it on her own scanner, just Google bariatric CT and you may be able to find a scanner that will be able to take bigger patients. Other thing that I try is often the radiation therapy folks have much wider bore because they have to put all the radiation kind of shields and other devices over the patient. So they do tend to have a larger bore gantry. So it might be worth to contact them. Concerns on imaging of large patients, noise. It goes high regardless of what kV or MA you may use. Now I'm talking about people who are morbidly obese, really very large patients. So whatever you might do, the noise may be high. There may be some artifacts like truncation artifacts or photon starvation and others. Okay, well, as you can see, this is a very large patient, which the BMI was close to 50 in this patient. And you can see that there is artifact, this bright rim around both the sides. This is truncation artifact. This is because the size or the tissues of the patient extend beyond the possible scan field of view allowed by the scanner, right? In addition, there is a lot of noise in this patient. Well, this was done, unfortunately, with a fixed MAS, right? Now, there are different views about whether we should be going with an automatic exposure control technique, and if we do, will your technique allow the scanner to rise or to increase the MAS sufficiently to overcome the deficit of photons, right? Then again, should you be combining it with slowing the gantry, maybe by slowing the gantry rotation speed? Should you be decreasing the pitch, or should you just go to a dual source CT and just power both the tubes to the max? Or apply some iterative reconstruction techniques? Well, one of the things that we find very useful is that if you know what organ or what region of interest you are looking for, right? For example, in this case, we were looking for liver. You can just off-center the patient, move him to the other side so that your region of interest comes in the somewhat relative center of the gantry. Now, not all large patients will allow you to do that because, they are quite large. They're already perhaps touching or encroaching on the aperture. But if there is a wiggle room, you should try to shift and bring the region of interest tentatively to the center so that A, you have less affection by the artifacts, and B, you can actually help improve the image quality. In these two images, we didn't change anything except that we just pushed the patient to the other side. Again, artifact, photon starvation, basically because the MAS is too low, the kV might be too low to be able to penetrate through the patient, and as a result, there is hardly anything that you can see in the liver in this case. Now, other thing that I mentioned was the field of view, right? So it's important that to realize that many times the field of view, the reconstructed field of view or the scan field of view also may not be sufficiently big to include all of the patient's anatomy. In this case, as you can see, that we do have some clipping that is occurring in the lateral abdominal wall, lateral pelvic wall, and most often it should not be an issue, except that unfortunately this patient happened to have melanoma. We did a PET CT, and you can see that there was this very bright hot spot, obviously a metastasis from melanoma, right, that we had excluded. Well, we basically went back and reconstructed the field of view, extended beyond what the technologists had done, right, and then we could see that metastasis on the CT also. So this was just the case that the technologists didn't really fully extend the field of view, not realizing that this was a melanoma case. But oftentimes you will realize that specifically in patients who are really large, you may not have the luxury of basically getting this area, right? So this is one of the limitations of the modality. Not all fat is bad. For example, in this patient who's 180 pounds, quite healthy, but not really very conducive to finding appendicitis or small things in the abdomen, right? Because there's hardly any intra-abdominal fat here. On the other hand, this 300-pound patient has a lot of intra-abdominal fat. It really helps separate the structure, see the blood vessels, and if there was appendicitis, we would have seen it very nicely, much more easily in this patient as compared to this patient. Often a trouble with small, skinny children, that you can have issues diagnosing appendicitis in a very small child. So not all fat is bad. However, not all fat is good for CT. If you have distribution of fat like this, where all the fat is inside the abdomen, separating the intestine here like this, it's good. But if you had fat outside, such as in this case, extraperitoneal fat, that's really not good, basically. What it does is it just causes more artifacts, increased noise, doesn't really separate the structures as well as we would like to. Well, so now we will discuss some practical implications. As we discussed before, for head CT, it's just important to check how much weight can you put on your CT table, right? So that's the important thing, because the patient's chest or abdomen is not going to go through the gantry, so you do not need to know what the gantry aperture size and what calculations you need to do, right? And the other thing is that since heads do not increase in size with obesity, generally speaking, it shouldn't really require you to make too many changes in the scan protocol, right? So you would just use whatever you're using as your routine protocol for this. How about the chest CT? And before we jump to the chest CT, there was also a paper that was published not so long back, in which what they reported was that, well, if you happen to have an old scanner which happened to have a limit of like 350 to 400 pound patient that you can put on the table, what these guys did was, well, they made the patient stand from the back of the gantry and just basically bend his head down, rested on the table on the headrest, and basically scanned the patient without even making him lie on the table. Not something that I do in my practice, right? But take my word for it, it's being published, right? There are things that people do to get around it, right? But for chest CT, again, you need to check both the weight as well as the aperture, right? You need to measure the patient's circumference as well as the patient's weight. Check with what your scanner would allow you. And now, as we learned yesterday, lungs, and I'll show you examples, lungs basically are not that much affected by either patient size or dose, right? So if you're looking for lung nodule, if you're doing lung cancer screening protocol, or just primarily just lung, right? Generally, you do not need to do much. I would still maintain a kV of 120. I would not go to 100 or 80 kV, right? But 120 should generally be sufficient. If you're just looking for lungs, you may need to increase your MAS to about 80 or at the most 100, right? But certainly you do not need to make it 200 or something, right? So yes, you do need to increase that MAS a little bit, but not as much. But if you're doing a study like a CT pulmonary embolism, or if you're looking for soft tissue in the chest, as we saw yesterday evening, you do require a little bit more extra. And this is where you will need to do several things. If you are interested in CTA, you do need to increase that contrast injection rate and volume. Remember, contrast helps you overcome and read through noise, right? So you do need to increase that rate. That rate is more important than that volume, right, for CTA studies. And then you may have to use 120 kV. I have found that 140 kV in the chest, just in the chest, if you're not interested in liver or adrenals and all that, 120 kV is sufficient even for the largest of the largest patient when you're doing just chest. But if you are going to be reading, or if you are interested in liver that comes with the chest, then you may need to go to 140 kV, right? Something that you may need to do for patients that are over 300 pounds or have a BMI of 40 or higher. And then, of course, iterative reconstruction techniques, if you have them, that's great. This is one of the places where you would apply them, right? One of the things that we do see is that most iterative reconstruction, certainly the first generation baselines, do very well when they have to handle noise, But when they have to handle some beam hardening artifacts or some photon starvation, you need to be very careful because of the changes in the image texture, right? Because when you denoise an image filled with artifacts, the artifacts can begin to look like something that you haven't seen before with your filtered bag, right? So that's something of a word of caution. Abdominal CT. Well, this is one place which gets most affected by patients who are very large, right? Here you may have to basically, the best case scenario is that you find the best scanner, right? The scanner that allows you to go to 120 kV, maybe close to 800 mA, maybe like 140 kV or 700 mA, a tube that is 100 kW basically. Or basically have a dual source where you can run both the tubes at high mA and kV because you do need information, right? Large gantry helps, and we saw the table that there is a variation in that. CT which tolerate higher weights, that would help. And of course, iterative reconstruction can be a big help if you have them. An excellent paper that came from Duke, from Schindler et al., and where they basically explored a number of things in patients who were very large. So one of the ways that you can actually milk more photons or get more photons out of your CT scanners, regardless whether they are newer or they are older, 16 or 8 slice or something, is the first thing is to maximize the MA. Now I'm talking about really big patients, 300 or over, BMI 40 or over. You are getting an abdominal CT, right? Increase the MA to whatever the max is. If that is only up to 400 or 450 that your scanner would allow, you go to step 2. You slow down the gantry, right? So in this paper, they maxed out their MA, which was around 400 at 140 kV. Very clever. And then the second step they did was basically increase the rotation time, or basically slowed down the gantry from 0.5 second to 1 second. If that doesn't give you the oomph that you need to go through the patient, then you need to go to the step 3, which is basically slow down the table speed, or basically get more photons delivered per unit area by slowing down the pitch, slowing down the speed of the table, and therefore these guys went from 1.75 as a pitch to 1.375, right? And also slowed down the table a little bit from their routine protocol to this. And they were able to get reasonably good image quality in these patients. Now, one thing to remember is that if you're doing a CT angiography of the abdomen, you're going to use 140 kV. Remember to increase the injection rate. You are going to lose about 30 to 35% of the worth of your iodine when you go higher on your kV. You need to get it back. The only way to get it back is basically by injecting the contrast at higher rate, more cc's per second. What about image thickness? Well, if you double the image thickness or the slice thickness, you basically will gain 41% in signal to noise ratio. So it does help. If you're looking at 2.5, you go to 5. If you're looking at 5, many scanners would not allow you to go to 10. What do you do then? Well, you get thin images out, 1.25 or 1.5 or 1 millimeter, put them in a 3D window, do a multi-planar reformat, and you can choose whatever slice thickness you want to, right? Because this would not be allowed prospectively or retrospectively in your usual conventional windows. That helps you cut the noise. That helps you, basically remove some of the artifacts, to some extent make them last, although it will increase some partial volume averaging. You will sacrifice some resolution, but if it's an uninterpretable scan at the highest dose that you can get, at least getting something out of it, getting thicker slices makes a lot of sense. Softer reconstruction kernels can also help. So if you're using detail, you go to standard. If you're using B50 or B30, you go to B20. Things like that can also help reduce noise. Iterative reconstruction technique, noise reduction filters also help. Looking at the images at wider window level, just the display settings sometimes help you. May not be much, but just sometimes it can help. Just making them a little bit wider. Certainly not going to help you to see low contrast structures. Lungs. As I said, this is a postmortem CT, of course, BMI of 37, 310-pound cadaver, and these are chest images, 3 millimeter, scanned from 35 milligray to 3 milligray. right? What do we see? Well, we do see a lot of ground glass opacity. We do see some nodular opacities here. We do see that there are some areas that are spared of the ground glass opacities at 35 milligray, not very different from what we see at 3 milligray. Right? Once again, if you're looking for just lungs, it's fine. How about liver? Well, this is the same patient basically, same BMI, everything scanned at the same time. Just the difference is this is 5 millimeter. It does help you cut down the noise. Right? 3 millimeter would not be as nice to look at in this case. But again, 3 milligray is not sufficient, 6 milligray is not sufficient. Perhaps 13 milligray is somewhat better. Okay. All right. Well, as I said, iterative reconstruction techniques can help, but sometimes when you're too low, it's not going to help. Cardiac CT, again, Dr. Raff actually discussed this. You may have to increase your KV. You may have to apply iterative reconstructions. And, really, I think someone had touched upon this, but this is a paper that we've been doing with Dr. George Zhu from RPI. And basically to remember that even though your CTDI will look higher in a very large patient, the actual absorbed doses in the organs are considerably lower, about 40 to 60% lower than what you would see in a normal size patient. Right? Because most of the dose gets absorbed in the skin and the fat underneath before it reaches the critical organs. So in summary, basically we have to check our weight and girth limits, we have to modify the techniques, and we have to appropriately adjust the reconstructed field of view. Now, in interest of time, because I have exceeded my brief, I'll be available here in the break to answer any questions that there might be.